Good morning, everybody. We are going to start with this symposium. First of all, I would like to welcome all of you. Thank you very much for joining us to this Biotech Healthcare Symposium at the 43rd Congress of the ESCRS. First of all, I would like to thank Biotech Healthcare for their trust they have placed in me for moderating this session. And I would also like to thank our fellow panelists and speakers. I am very well accompanied. We have three speakers. Dr. Cabanas from Spain, head of the department of the University Hospital Virgen del Rocío in Sevilla. And two speakers from India, Dr. Ramamurthy and Dr. Xtense. They are both leading names in the cataract and refractive surgery. And also we have two fellow panelists, Dr. Cancino, on my left. He is a leading cataract and refractive surgeon in Spain, and Dr. Geckel from Germany, another leading cataract and refractive surgery. So we are going to start with the scientific program. We have three hot and nice topics with three great speakers. So I encourage all of you to engage with the speakers and the panelists at the end of each talk for doing 5-7 minutes of questions and answers. So first, I invite Dr. Ramamurthy from India to talk about achieving full range of vision with Optiflex, Xtense, Comfort Plus IOLs.
Thank you so much, Dr. Carlos, for that nice introduction, and thank you, Biotech, for putting together this session and having me as one of the speakers. I think what I am going to be talking to you about the next few minutes is a new kid off the block and initial experience we have had with this lens. As a matter of financial disclosure, I am a consultant to Biotech, and my topic is achieving full range of vision with Optiflex, Xtense, Comfort Plus IOLs. This is the lens I'm going to be talking to you about. And we have the full range of vision, multifocal intraocular lenses, very well established. And recently, EDOF lenses have been grabbing a lot of attention. And to some extent, they are taking a significant amount of market share. The Optiflex Xtense is a sort of a EDOF lens, a refractive EDOF lens, which almost accomplishes what we do with a full range of vision intraocular lenses. One of the factors, attractive factors of this lens is that the photic phenomena, because of the design of the lens, is almost comparable to that of the monofocal intraocular lenses. It's a very unique segmented refractive design that we have. And as you can see over here, we have this first zone, which is about 1.55 millimeters in diameter, which is larger than the diameter of most of the buttons of the multifocal intraocular lenses. This has a higher power with positive spherical aberration. That is, in case it's a plus 20 diopter intraocular lens, the base power is significantly higher. Both the spherical aberration and as well as the power that's added is proprietary information. So we really are not aware of the exact dimensions. Suffice it to say it's higher. And then as far as the zone 2 and zone 5 are concerned, this contains the actual power of the intraocular lens that's labeled along with positive spherical aberration. Zone 3 is a combination of zone 1 and zone 5, where the power is somewhere in between the zone 1 and 5, and also that also has positive spherical aberration. Zone 4 is the interesting component, where it has 6 segments of 60 degrees each, and basically the power in this takes care of, it's again, it alternates between what is the power in the zone 1 and zone 5. So essentially this has different areas of the lens which is distributed for distance and near, distance and intermediate, and along with positive spherical aberration that's incorporated in the lens, this lens seems to take care of seamlessly distance from near all the way to the near, and also the quality of vision that you get with these lenses is quite good. And because of the large 1.55 millimeters central diameter, a large angle kappa or angle alpha is also not a contraindication for implantation of these lenses. It comes in a preloaded platform with an aspheric surface, and the extended depth of focus is achieved by optimizing the power and asphericity of each refractive zone. The 60-degree segmented zone is what is quite remarkable about this lens, in the sense that it has a combination of distance and near and distance and intermediate combined together, so that once implanted, even if the pupils are dilating, even in the mesopic or scotopic conditions, there is a certain element of distance and near vision, and there is no diminution of near vision once even in dim light conditions, and it offers spectacle independence for all activities. As you can see, this is a through focus curve of this particular lens, and there is a significant peak that is there as far as the distance is concerned. Again, one for near. But at this is actually an optical bench study, and at 3 millimeter pupil at 50 millimeters per line frequency, what you see is this was a matter of concern to me, is that there is a significant dip as far as the intermediate distance is concerned. But what we find in implantation, subsequent implantation in patients, is that because of the inherent presbyopia correction that is there in the patient, this intermediate vision is taken care of, so that this drop in intermediate vision is sort of compensated by the spherical aberration and other components that offers a reasonable amount of intermediate visual acuity, so that there is a seamless vision from distance to near. As you can see in these USAF images, there's as far as these images is concerned, these are for the larger font sizes. Number 4 is for the 6/9, corresponds to 6/9 vision. Number 5 corresponds to 6/6 vision. And what you see is when you have intermediate vision of 1.2 diopters in optical bench studies, there is a significant blurring. And this is essentially taken care of by subjective accommodation of these patients, because of which from distance, intermediate to near, all is taken care of. And when you look at 3 or 3.2 diopters of defocus, you find that the quality of vision is quite good. And even for near vision, the distance near and intermediate is quite adequately taken care of. And from 0 diopters to 4.4 diopters of defocus, this lens seems to work reasonably well, at least in the optical bench studies. And as you can see, the implantation of the lens is quite easy. It comes in a preloaded platform. I just taken it out for the purpose of demonstration. You can see the 5 individual zones that are there. The central zone of 1.5 millimeters, and especially the zone 4, which is segmented into 6 different zones of 60 degrees each, taking care of distance near and intermediate. It comfortably goes in through a 2.4, 2.2 millimeter incision. It's a hydrophobic acrylic platform, a single piece intraocular lens, having all the with a square edge design, having all the potential advantage of this particular platform that we are all familiar with. You can see that it's not really a diffractive rings that are there in this lens. Neither is it a zonal progressive lens, but it's a unique platform where it's a refractive lens, and the profile of the lens is such that the shift from one zone to another is quite seamless, and that's one of the reasons that the dysphotopsia is quite less. And as far as the post-operative 3 months clinical outcome, I must confess that this is a very, very initial experience that we have had. We implanted 12 eyes, and there are 30 eyes that have been implanted in 5 different centers. What I am going to be presenting to you is a combined analysis of what we found. And all these patients, of the 30 eyes, 10 were male patients, 5 were female patients, all were bilaterally implanted. Because the toric version as of now is not available, we made sure that the cylindrical power in all these patients, where the corneal cylinder was less than 0.5 diopters, and it was normal walk in the park cases, and the surgery itself was quite routine. As you can see over here, as far as the refractive outcome was concerned, in all these cases, it was the Barrett Universal 2 formula that was used, and 80% of these eyes ended up with emmetropia. In the rest 20% of the eyes, it was within 0.5 diopters of defocus, so that it was quite acceptable as far as the refractive outcome is concerned. So obviously, it's credit not only to the lens, also to the formula that's being used. And as distant visual acuity is concerned, which is most important, and patients do not want any compromise in this, 100% of the eyes had, 90% of the eyes had an uncorrected distant visual acuity of 6/6, while the 100% of the eyes had 6/9 or 20/25 or better uncorrected visual acuity, which is fairly satisfying. As far as the intermediate visual acuity is concerned, there was a small drop, and it's in about 70% of the eyes it was 20/20 or better, while nearly 98% of the eyes it was 20/25 or better. And when it came to near visual acuity, which is most important, you find that it was only in about one-third of the patients, one-third of the eyes, it was 20/20 or better. And it rose up to about 86% in 2025. And when you talk about functional near vision, which is in the range of 2032 or 2040, it was 100%. So bilaterally implanted, even though these are the results of singular implantation, and when you bilaterally implanted, most of these patients were able to function without the need for glasses, though they did have a little bit of strain as far as the N6 visual acuity is concerned. What about contrast sensitivity? As we all know, when we buy vision for all distances using the currency of contrast, invariably there is a loss of contrast, and it's a loss of quality of vision that bothers all our patients who have multifocal intraocular lenses implanted. In normal healthy eyes, the contrast sensitivity, the log value is about 1.8 to 2. And once you implant a multifocal intraocular lenses, it's well acknowledged that it drops down to between 1.38 to 1.67. As far as this Xtense lens is concerned, the contrast sensitivity varied between 1.35 to 1.65 log units with an average of 1.55. So as far as the contrast is concerned, it was comparable to the moderate levels of multifocal or trifocal intraocular lenses, and there was no diminution as far as the contrast sensitivity is concerned. Monocular defocus curve, as you can see, there was a 0.2 logmar or better, up to 2.8 diopters of defocus. And when it comes to bifocal implantation, bilateral implantation, then it improved to about 0.2 logmar or better, up to minus 3.2 diopters of defocus. That is the reason most of the patients who are implanted binocularly were able to function quite comfortably without glasses. How does it function in comparison to the other popular trifocal lenses that are available, trifocal EDOF lenses that are available in the market? And these are actually, the charts are compared with what is published in the websites of these particular lenses, the Galaxy, the POC, the Acrisoft, etc. They're all quite comparable. As you can see, when it comes to intermediate and near, the drop-off as far as the intermediate and near is concerned is significantly more with the other lenses compared to the Xtense. And Xtense seems to have a fairly larger, flatter plateau, because of which even the intermediate and near vision seems to be taken care of a little better. When it comes to binocular defocus curve, the difference becomes even more prominent, and up to about minus 3 to 3.2 diopters of defocus, this lens seems to function quite well. But in other cases, by around minus 2 to 2.5, there's a significant drop-off that occurs, and that I feel is the obvious advantage of these lenses over the currently available other platforms. Dysphotopsia Behçetmen, as you can see over here, patients were specifically questioned about distorted vision, color perception, ghosting, glare, halos, etc. 100% of these eyes, it's not as if they never complained of seeing any, but none of them were really bothered by it, and they could go about all their normal visual activities before without being concerned about it. As far as spectacle independence and preference is concerned, you can see when they're specifically asked, would you recommend the same intraocular lenses to others? Would you choose the same intraocular lens again? What about your comfort with spectacle independence? Especially in those cases bilaterally implanted, it was 100% yes. Having said this, I must say that we have implanted just 12 eyes, and this is an analysis of just 30 eyes. So it is initial impressions about this lens. Obviously, this lens has to be commercialized and significant implantation of these lenses has to taken place in the community for us to accept this as a viable alternative. Patient satisfaction is concerned. Distance vision, they were all very satisfied, and that's, I think, most important. Obviously, it varied between excellent to very good. The same was for intermediate vision. As far as near visual acuity is concerned, as I mentioned, it achieved N6 visual acuity only in about 40% of the cases. That was the reason that only 11% of the patients felt that the near visual acuity was good, even though bilaterally implanted, these patients improved to N8 or N6 visual acuity. As far as visual lifestyle activities are concerned, again, it was classified as excellent, very good, good and average. Now, all these patients ranged between very good to excellent. And the common activities like driving at day, driving at night, using mobile phones, watching television, cooking, using computers, shaving, makeup, reading newspaper. These are not just what you see on the bench or what's the visual estimation, but the experience of the patient, which ultimately matters the most. In all these things, the majority of them was excellent. In some of them, it varied from very good to good. But obviously, these patients could comfortably do most of these activities without relying on external crutches. So in conclusion, Optiflex Xtense Comfort Plus can be considered as a full range of vision EDOF IOL, giving patients a true spectacle independence for day-to-day activities. The most importantly, the contrast sensitivity loss and the photic phenomena is comparable to the monofocal intraocular lenses. So in case you can get, obviously there are several other alternatives that are available to us today, but in case you are able to get the advantage of vision for all distances with a small compromise as far as near vision is concerned, and at the same time the dysphotopsia problem is not there, that would be a great way to go. And this is at least the initial experience suggests that this lens could be a viable platform for that. Thank you so much for your kind attention.
Thank you very much, Dan. Any questions from the audience? Any question from Dr. Ramamurthy? From the panel?
Yeah, you talk about the difference about the focus curve. It's almost flat. It's very good. But what really differentiates from other EDOF platforms?
The other EDOF platforms, as you see in the graphs itself that was projected, the ones we considered with the POC. And as you can see, the drop off, those lenses also quite function quite well. As far as distance visual acuity is concerned, especially if you hit metropia, all of them seem to function quite well. It is only the intermediate and near vision that the difference becomes more obvious. And especially in the near vision, it tends to drop off from about plus 2 diopters, 2 diopters of defocus, because of which beyond 50 centimeters, they seem to be quite inadequate. While in this case, it's almost up to 2.8 diopters, get a fairly flat curve. And once binocularly implanted, you find that it's even better. It's almost 3.2 diopters. And that's the reason that this lens seems to be a little better compared to the other currently available, like the Galaxy, the POC, these lenses. Compared to that, there's some amount of near vision capability that comes in without a compromise as far as the quality of vision is concerned.
Dr. Ramamurthy, since you started with this IOL, have you changed your point of view about how you consult your patients, or how do you manage your patient expectations? As the near visual acuity seems to be very good.
Obviously, this is only 12 eyes I've implanted. So, but it's general consensus about how I talk to my patients about full range of vision intraocular lenses and EDOF lenses. Essentially, when we talk about these lenses, it's a compromise either in the range of vision or in the quality of vision. So if a patient wants a true trifocal intraocular lens, then if you hit metropia, a good quality lens, then distance near and intermediate is taken care of. But the dysphotopsia is a problem which tends to go away in most patients. There are some who gets bothered, especially if night vision, night driving, etc. is important for them. They are bothered by that. On the other hand, if you go for the currently available EDOFs, then these patients, the quality of vision is reasonably good. At least with some of them, it's as good as a monofocal intraocular lens. But then as far as the quantity of vision is concerned, with near vision, it's N10, N8, they invariably required +1, +1.5 diopters as far as near vision is concerned. So essentially, we are constantly looking for a lens which could give us a range of visions from distance to near, with quality of vision that's comparable to a monofocal intraocular lens. Obviously, we are not there yet, and I think this lens is a progression in that step. And the fact that it does not have any diffractive rings, it has a unique refractive pattern with with the distribution of the power in combination with positive spherical aberration, allowing it to give you a range of vision with a mild compromise as far as the quality of vision is concerned.
Okay, and as a refractive optic, how do you think the centration of the IOL or the pupil size could affect your outcomes?
As such, the kind of emphasis we used to lay on angle alpha, angle kappa has significantly come down now compared to what we initially thought. And even for other trifocals, I do not focus on that too much. And especially most of the other trifocals or multifocals have a central disc of just about 1.1 or less than that, or 1.16, while this has a 1.55 millimeters central disc, which is essentially for distance and near. Because of that, even if there is a slight amount of defocus, this lens is likely to function quite well.
Okay. Is there any patient that you wouldn't recommend this lens? Because you're inducing some spherical aberration, right? So maybe in patients with high oral aberrations, you don't recommend this lens,
Absolutely.
Which is the ideal patient for.
This lens has a fair amount of positive spherical aberration. So frankly, though I did ask, because of its proprietary information, I don't have access to what exactly is the positive spherical aberration. And it's a very initial experience. So right now, we have done it on simple virgin eyes without any problem. So the usual contraindications for any multifocals are EDOFs like suboptimal optical surface or a macular problem. These are issues or post-refractive surgery. Obviously, we still have to see whether these lenses will function well.
Nice, interesting data, Dr. Ramamurthy. How would you target your biometry? Because there's a positive spherical aberration. Most of the other monofocal lenses or EDOF lenses which we use are negative spherical aberration. So would you kind of target the first plus or the first minus? Because this got a small 1.5 mm central zone with a positive spherical aberration. So more rays would probably come to focus in front of the retina. So would you kind of aim for a little bit of hyperopia so the distance vision is good in one eye, and maybe emetropia or like a minus, first minus in the other eye? Do you think that approach would be good?
I think, your question is very relevant in the sense that this was an initial study and a pre-market approach study. So what we have asked was to aim at emetropia in all the eyes and not play around with the power. But it stands to reason that if I were to use this eye, these lenses, I would aim for the first minus in the first eye, and depending upon, and of course, the point you make about positive spherical aberration, unlike the negative spherical aberration, most of our common lenses also has to be taken into consideration. And depending upon the outcome in the first eye, I will titrate the power in the second eye.
Okay, thank you, Dan.